Right, in this section, we consider specific drug treatment. You will find that many of the questions in the exams relate to drug interactions. Some of them are predictable, and they're based on induction and inhibition, and some are bizarre, unpredictable, and I'll cover a few of these. So let's start with our first question. A 25-year-old man presents to A&E with an acute exacerbation of asthma, failing to respond to bronchodilators. As part of the medical team, you're asked to review him, and you decide to give intravenous magnesium. Which of the following statements is true regarding intravenous magnesium? Please consider these options. If we look at the answers, the usual dose is not 2 milligrams, it's 2 grams, so it's a really high dose that we're giving. Magnesium increases acetylcholine release. Actually, it's the converse. It inhibits acetylcholine release at the neuromuscular junction, and what this results in is dilatation of the smooth muscle. Hypertension is commonly seen after treatment. Actually, it's the converse. Hypotension is seen usually when you've started the first dose. Within the first few minutes, you will see the blood pressure dropping. It relaxes bronchial smooth muscles. Drowsiness and coma in this situation are most likely to occur. They don't. If a big dose of magnesium is given for a long time, it can cause drowsiness and coma. But with a one-off dose that we give in acute asthma, it will not cause this. In this particular question, drowsiness and coma has resulted from hypercapnia, from the raised CO2 retention in someone presenting with acute asthma. What we see next is the typical bronchiole that presents in an asthmatic, where you have smooth muscle contraction, and the recent interest now is in magnesium through the ACH and the neuromuscular junction. It causes the dilatation from acute asthma to the normal bronchiole of the smooth muscles. On the right, we have the bronchioles of an asthmatic patient. What you will note is contraction of the airways by the smooth muscle. On the left, we have the normal bronchioles, and to go from that to that, you need relaxation of the smooth muscle. This is where magnesium has its role. So at the neuromuscular junction, it will lead to a decrease in ACH and relaxation of the smooth muscles. If we go to the next question, in general medical clinic, you are reviewing a patient with difficult to treat angina, and you consider a trial with nicorandil to be appropriate. Which of the following statements is true concerning the anti-anginal drug nicorandil? This is a new drug which is now used by cardiologists. Please consider these options. The only correct answer here is A. So oral ulcerations are rare, but they do occur with nicorandil. It does not inhibit the ATP-dependent potassium channels. If anything, it activates those channels. It does not increase ventricular filling. It does the opposite. It causes peripheral vasodilatation and thereby decreasing ventricular filling pressures. Headaches are actually common because of the nitrate component. About 35% of patients have headaches. Its hypertensive effect is potentiated by sildenafil, Viagra, which are phosphodiesterase inhibitors. So that is wrong because of the word not. And read the question very carefully for when they use not or when they use the active. Let's consider the next question pertaining to ACE inhibitors. Cough, as a side effect of ACE inhibitor, occurs because of which of the following? Please consider these options. I'll go through each of them. I'll start with the first. It's very difficult to pronounce, dysgeusia. ACE inhibitors cause dysgeusia, which is dryness and metallic taste in the mouth. They do that. ACE inhibitors are well known for doing that, but that's not the reason that they cause cough. They cause bronchoconstriction. They do not. Bronchoconstriction would be beta blockers. They affect the breakdown of bradykinin within the lungs, and that's the correct answer, and I'll explain that in the next slide. But let's consider the other options. ACE inhibitors increase bronchial mucus secretions. They do not affect mucosal secretions, and they cause vasodilatation, which they do, but this does not result in pulmonary congestion. So that answer is wrong. The only correct answer is C, and when we go to see the next slide, we see why. ACE inhibitors act in two places. They block in the lungs the conversion of angiotensin 1 to angiotensin 2. This is very important if we think about the renin-angiotensin system. Angiotensinogen is made in the kidneys by the juxtaglomerular complex, converted to angiotensin 1 to 2 is in the lungs. ACE inhibitors in the lungs will block the breakdown of bradykinin, and it's the buildup of bradykinin that causes cough. Let's consider the next question, which is to do with epistaxis. A 67-year-old man on warfarin presents with epistaxis. On examination, he is tachycardic and requires emergency treatment from the ENT services. It transpires that he has inadvertently taken too much warfarin and his INR is 8.7. What is the most appropriate management? Consider all these options for treatment of bleeding and epistaxis and choose which one is appropriate in his particular case. This is a very important question, both clinically and also in the exams, because they give you a close answer to this. I think the red herring here is vitamin K. We all know that vitamin K is the antidote for warfarin, and so you would have considered that answer. The problem here is that this patient is bleeding and he has an INR of 8.7. If he wasn't bleeding and had an INR of 8.7, vitamin K would have been the correct answer. However, it takes a long time to act. This question is asking us to act quite quickly. And so what you want to do is give fresh frozen plasma. Cryoprecipitate is the wrong answer because that's what you would give someone who is bleeding due to hemophilia, so lack of factor 8 or factor 9. Desmopressin and tranexamic acid is also what you would give hemophiliacs. It's antifibrinolytic and is not affected by warfarin. Warfarin mainly you would use vitamin K, but in the acute setting you would use fresh frozen plasma. Let's consider antiepileptic medication. A 29-year-old woman on antiepileptic medication presents with ankle swelling, tremor, weight gain, and thinning of the hair, also known as alopecia. Which medication is most likely to cause these symptoms? The correct answer is valproate. I will talk about the side effects of each of the following because they're very important and some of them overlap. These are all antiepileptic medication. Phenytoin will cause gum hypertrophy. I think that's the major presentation in the exams. Gum hypertrophy and the opposite, not thinning of hair, but excess hair. So for the balding men, they will get hirsutism or growth of hair. It can also cause osteomalacia. Phenobarbital will cause folate deficiency and osteomalacia as well. Carbamazepine will cause a low sodium, it will cause ataxia, and it can cause nystagmus. It's only really valproate which will cause that triad: ankle swelling, tremor, and weight gain. And then, of course, it can also cause alopecia or thinning of the hair. In this question, let us consider some more antiepileptics. Antiepileptics are very topical in the exams. In this case, we have a 30-year-old woman on treatment for secondary generalized tonic-clonic seizure. She comes in complaining of anorexia, nausea, and generalized fatigue. On examination, there's no peripheral edema. Blood tests reveal a low sodium of 124, potassium of 4, plasma osmolality of 200. What antiepileptic drug has she been prescribed? Please consider these antiepileptic medication. There is only one correct answer, and I think the clue here was the low sodium. So carbamazepine is the only one there that will cause a low sodium and does this by a syndrome of inappropriate ADH secretion. Acetazolamide can cause diarrhea and vomiting, but not really a low sodium. All the other anti-epileptic drugs, including Keppra, will not cause the low sodium. Let's consider question number 7. A 60-year-old retired surgeon is admitted with a short history of bizarre behavior and paranoid symptoms. He has evidence of coarse tremor, nystagmus, and ataxic gait. There is a history of excessive drinking of alcohol since retirement. Which of the following immediate treatments would be of great benefit to him? Please consider these options. There is only one correct answer. What he is presenting with is Wernicke's encephalopathy. So he has the triad there of tremor, nystagmus, and ataxic gait. This is a very serious situation and should be treated quite urgently with vitamin B1, which is thiamine. Diazepam is used to treat alcohol withdrawal. In fact, what you'd use would be chlordiazepoxide. Naltrexone, acamprosate, and disulfiram are used for the treatment of alcohol abuse, so to try to get someone who is addicted off alcohol. This question is talking about an emergency situation where someone is presenting with Wernicke's encephalopathy. You do not want them to proceed on to course of psychosis, which is irreversible. Let us consider other problems that alcoholics or alcohol excess can lead to. I think the other emergency other than Wernicke's is acute withdrawal of alcohol. So someone who has been drinking excessively and suddenly stops drinking alcohol. They can present with vomiting, and they can even have hematemesis, one of the medical emergencies. They can come in with hallucinations. They can see lots of rats crawling up walls, they can hear voices, and they can have DTs, or they can have seizures, as we call them. All these need to be treated as alcohol withdrawal with chlordiazepoxide, also known as Librium. So the two real emergencies in terms of CNS presentations are Wernicke's encephalopathy and the converse, which is withdrawal, alcohol withdrawal, or delirium tremens, DTs. Let us now consider question number 8. A patient with hypertension has been started on losartan. By which mechanism of action is this drug most likely to lower blood pressure? I think this is the newest addition to the antihypertensives. Please consider the following for the mechanism of action. Losartan, like valsartan and olmesartan, all the drugs that end in sartan are ARBs, angiotensin II receptor blockers. They are similar to ACE inhibitors, but they are not ACE inhibitors, and so A is false. But we'll look at how they act, their mechanism of action, in the next slide. If we look at this slide, looking at the mechanism of ACE inhibitors, angiotensinogen is made in the liver. It's converted to angiotensin I in the JG, the juxtaglomerular complex in the kidneys. It is then converted from angiotensin I to angiotensin II in the lungs by the enzyme ACE. And this is where ACE inhibitors work. They block the conversion of angiotensin I to angiotensin II in the lungs. ACE inhibitors also block the breakdown of bradykinin in the lungs, and thereby the buildup of bradykinin leads to cough as a side effect. We have covered clinical pharmacology, including drug overdose, drug metabolism, and finally specific drug treatment, including drug interactions. These are the most important areas that are covered in the exams in the part 1. Good luck in the coming up part 1 exams.